I'm Arushi from SRM Medical College, and it is a privilege for me to serve as a moderator for today's session on behalf of the Indian Medical Association Medical Students Network, IMA-MSN Tamil Nadu State Branch. I extend a very warm welcome to all the respected dignitaries, our esteemed speaker, and all the participants who have joined us today for this insightful webinar, Closer Than Care, Transforming Newborn Survival Through Kangaroo Care Mother Care. At the beginning, I would like to respectfully guidance and encouragement provided by the patrons of IMA Tamil Nadu State Branch, Dr. B. Sridhar Sir, State President, IMA TNSB, Dr. P. Sengutavan Sir, IMA Past President, IMA TNSB, Dr. A. K. Ravikumar Sir, President-elect 2027, IMA TNSB, Dr. N. R. Tyagarajan Sir, President-elect 2027, IMA TNSB, Dr. M. Tiravayam Mohan Sir, State General Secretary, IMA TNSB, Dr. D. Solomon Jaya Sir, State Finance Secretary, IMA TNSB. I would also like to convey my sincere regards to our state leadership team, Dr. R. Annamale Sir, Chairman, IMA-MSN TNSB, Dr. S. Jamnarani Ma'am, Co-Chairman, IMA-MSN TNSB, Dr. V.S. Hariharan Sir, Chairman, IMA JDN TNSB, Dr. Kannan Rajendran Sir, Convener, IMA-MSN Subcommittee, and a special appreciation to the state team members who continuously support the activities of the Medical Students Network, Dr. Arnagiri Sir, Convener, IMA-MSN TNSB, Dr. Ajay Karthik Sir, General Secretary, IMA-MSN TNSB, Dr. Balahariharan Sir, Co-Convener, IMA-MSN TNSB, Dr. Hariram Sir, Co-Convener, IMA-MSN TNSB. Today, we focus on one of the most effective and compassionate approaches to in newborn care, kangaroo mother care, by promoting continuous skin-to-skin contact, exclusive breastfeeding, and early parental involvement. KMC plays a vital role in improving the survival and well-being of premature and low birth weight babies. As healthcare continues to advance, strengthening awareness and implementation of KMC brings us one step closer to ensuring healthier beginnings and better neonatal outcomes for every child. It is my great privilege to introduce our esteemed speaker, Dr. Apeksha Anand Ma'am. She is highly respected pediatrician and a senior consultant and in charge of pediatrics at Sai Group of Hospitals, Chennai, with her expertise in neonatal and pediatric healthcare, along with her dedication towards improving child health and parent counseling. She continues to inspire both healthcare professionals and medical students alike. We are truly honored to have you with us, ma'am, today. I am certain that today's session will be highly engaging, informative, and insightful under your guidance and presentation. Without further delay, let's begin today's session.
Thank you so much for your kind words, and thank you IMA Tamil Nadu branch and MSN JDN group for giving me this wonderful opportunity. So let's not wait, since everybody, we have a very good strength. So I'm so happy. So I want to tell you that the reason we are doing this is tomorrow is our International Kangaroo Mother Care Awareness Day. So as a doctor, as a healthcare professional, actually anybody can initiate kangaroo care. So today I am here to enlighten you all the importance, and following my talk, we have a very senior person in the field of nutrition and pediatrics to help us know more. So is my screen visible? Can I start? Okay. So I chose this topic because it's something very close to my heart, and the picture there is myself and my kid. So I'll start with saying that my child was a term child, but it was a low birth weight. So I did give kangaroo mother care, and I feel it was something which helped me get my son to a good weight. Okay. So a brief history. So she already said, and I'm sure all of you know, kangaroo mother care is a very simple and a life-saving neonatal practice. Skin-to-skin contact. It is recommended in stable preterm babies, low birth weight infants. It promotes warmth, bonding, and also breastfeeding. It's extremely low cost, actually cost effective, and it's a very good alternative to incubator care. brief history. So it started around 1978. It was started by Dr. Edgar. At that point, there was a lot of shortage of incubators. The neonatal deaths were very high and the hospital infections were rising. So sir took the example of a kangaroo, how it takes care of its child. So he started placing these preterm infants in skin-to-skin contact with. He noticed that eventually the children's outcomes were better. So by 1980s, it refined and he promoted kangaroo mother care. So he had a lot of challenges initially, but then with the success of kangaroo mother care in the 2000s, the World Health Organization and UNICEF, both of them started recognizing, and in our modern era, it is the choice for preterm, which are stable and low birth weight babies. So everything good happens has a challenge behind. So that's what I wanted to say. But the outcome is always good. So never give up in anything which we do. So these are the three components. One is skin to skin contact. Second is the exclusive breastfeeding. Third is early discharged. Okay, so let me touch the few points. There is always, we say, an anatomical connection between the mother and child. Though the child comes out of the womb, the mother and child hold a very close bond. So the mother's chest acts as a dynamic radiator. So it heats up the baby if it is cold and cools down the baby if it's too warm. So the direct skin to skin contact is more efficient than any medical incubator. So if you have all worked in a newborn setting or an NICU, you would have seen that sometimes the temperature in a newborns, the thermoregulation becomes a major challenge. So you go to hypothermia, your thermals are beeping. So if you see, once the child is put in kangaroo care, mostly the temperature recorded has been stable. So why kangaroo care? So physiological benefits are many. One is vital stability, it regulates heart rate and breathing patterns. Neurodevelopment, it is proven to increase quiet sleep and helps in brain maturation. Immunity, it helps in colonization with maternal flora, hence prevents severe infections. Also metabolic balance, reduces energy spent on staying warm because of the mother, which acts as a radiant. Other than the baby, the mother also has more benefits. First is 100% healing, natural, okay, and then oxytocin. So what happens is, so there is enhanced milk production and uterine recovery. Both of this is happening when there is skin to skin contact. So we all know that a mother goes through a very tough phase after delivery due to hormonal changes. So we call it postpartum blues or postpartum depression. It is always more when a child is in NICU. So if the mother is given the baby, so mother is more confident and helps her in easy recovery. And also it gets confidence to the mother. Though the baby is small, she is able to handle it and help the child. So this is the position of KMC. So you have to keep as I can point out, I think you are seeing the picture here. So you should it is done with bare chest. The child has to be kept in a vertical position between the mother's breasts. So head is turned towards one side so that we keep the airway clear. The child is not choked or does not have any aspiration or any clogging. So leg, we keep it in frog leg position. Hips are flexed and arms are tucked in. So the child has a proper grasp. And then we usually, we can either use a binder or a wrap for safety so that the baby does not fall. This is mainly because the babies will be very low birth weight and the mothers will be scared to handle. But if the mother is confident enough, so you can even hold with hands, and then over that we cover the child with a blanket or the mother's chest. Okay, so there are a lot of myths in regarding kangaroo mother care, which is there with elders and many people around. So they say it's only for preemies. I would say no. Any term child which is low birth weight, so low birth weight is less than 2.5 kgs, IUGR, that is called as intrauterine growth retardation. So they also benefit in stability and in good weight gain and also brain growth. So most important thing in our society is Romanara kolde tuki vecha, it spoils the baby. No. So we say it builds secure attachment and leads to a calmer infant on the later days. Then they say mother is too weak. How can she handle such a small baby? So no, KMC actually helps in mother's physical recovery, mental recovery, helps in balance, and also increase in, as I said, milk production. So more myths. There are only say that only mothers can do KMC. Not really. So we need any person who is healthy, even a father, a grandmother, anybody can do. So the KMC session, each session has to be minimum 45 minutes, and we asked them to do it for at least 8 hours a day. 6 to 8 hours a day is good enough. So we can start slowly and then go on increasing as the child is comfortable. And they also say that tiny babies cannot tolerate KMC. So we have seen as small as 1 kilo babies put on mother's breasts, father breasts in NICU, and they do extremely well. We have seen that the monitors show better heart rates, better saturations, and better oxygen levels when they are on KMC position. So once the child is stable, off ventilator or a CPAP, even in nasal prongs, see I put a picture also, we put directly on the KMC position. And they say no, incubators are always superior. What is expensive is more superior. Again, that's a myth. So not all expensive things are actually superior. So this is very, very simple, but yet very effective. And they say that once the baby starts gaining weight, we should stop KMC. Not really. So whenever we discharge a preterm baby, what we tell the mother is, you please continue this at home. 8 to 10 hours day is good enough. So when exactly to stop KMC, when they ask, we'll tell the child itself will start getting uncomfortable. So once the child start growing, start feeling hot, they only come out of the KMC position. So that's when we decide to stop, and preferably up to 2.5 kg we ask to continue. So I always say that KMC doesn't start or stop at NICU. It has to continue in wards, home. So encouragement from the family becomes very, very important. It is extremely cost effective in all settings. And any of you who are at least trained and who are attending this can definitely counsel a mother for a kangaroo care. Even if the doctor forgets, even if the staff nurse forgets, have to make sure that whoever is around takes responsibility to tell the mother during discharge. So it also helps us send home early. So these are few statistics, very standard references, which I have written mainly. There is KMC has reduced mortality by about 40%. Immediate KMC may save up to 1,50,000 lives in a year. Sepsis related deaths are reduced by 36%, and it is also proven to improve weight gain and breastfeeding in the follow up. So long-term studies have also shown that improved brain development, higher school attendance level, stronger emotional bonding, and better quality of life in KMC infants. So these are all in standard journals with after proper studies. So I would say kangaroo mother care is an evidence-based, simple, and a very effective tool. Womb to warmth emphasizes human connection in neonatal care, and our tiny acts of care can save multiple lives with cost effectiveness. So thank you, and any questions I am here to answer.
Guys, if you have any doubts, please do ask, ma'am.
Yes, so if you're scared to ask, so I have shared my details. You can email me your doubts at any point of time. Yes, please go ahead.
What is kangaroo mother care? If anyone knows the answer, please come up and answer the question. What have you understood from the above webinar?
So you can type in the chat also. We are in the Gen Z batch who are better in typing than talking, I feel. You're quicker than us in chatting and replying. So come on.
Ma'am, hello.
Yes, Niveta, tell us.
Kangaroo mother care is when there's a preterm baby and we use direct skin to skin contact and exclusive breastfeeding to care for the baby.
Very good. Nice. See, I told you there are a lot of responses in the chat box. Right. So I'm happy at least 5 of you are listening and are able to answer. Very good.
Which babies are recommended for KMC?
Preterm babies or low birth weight babies.
Very good. So she listened to my myth.
What are the major benefits of KMC?
Very nice. So we get all good answers.
Why is KMC considered a low-cost alternative to incubator care?
Yes, no expensive machines. Mother. Yes, natural. No equipments. Very nice. Very good. You have a very enthusiastic crowd.
What are the basic pillars of KMC?
The skin.
Oh, I got exited.
Hello.
Yes, skin to skin
Uh,
contact. Okay, then the other components. There are three components. Breastfeeding, very good. Last one.
hello.
Yes, you can talk.
Ma'am, I wanted to know if there are like any contraindications of KMC, like are there any challenges or something?
Yes, the contraindications again, unstable. So whenever we tell preterms, that is why I added the term stable preterms. So preterms can be either early to extreme preterm, less than 28 weeker, 28 to 32 weeker becomes early preterm, moderate preterm, late preterm. So there are four categories under preterm itself. So whenever the child goes down the our like gestational age, the risks or complications are more. So that is when we contraindicate it, so that once the baby is stable only we put to the test. So yes, challenges are many, because you see the mother has to be stable and the father has to be stable, and we have to get the mother inside the NICU. There is risk of infections to the other children when we get another person inside to sit 8 hours, right? So there are multiple factors. So yes, but then we are all doing, I think most NICUs level 2 and level 3, which is there in at least in Chennai, Bangalore, Mysore, wherever I have worked till now, I have seen very, very good KMCs being initiated very early.
Okay, thank you, ma'am.
So have you, or has any of you worked in or seen an NICU and KMC being performed? Have you been eager to go and ask your residents or consultants, like, what are they doing, sir? Why have the child there? So I have 130 participants. So I want to know if at least one or two of you have seen this happen. Not personally, but I have seen it in shows, right? Very good. I saw my aunt doing when I was young. Very nice. didn't see but was interested to see. Okay. So maybe once if you are in any of the medical field, either a medical student, so once you come to internship, when you have pediatric postings, I'm very sure you will be posted in neonatal intensive care. So you will be able to experience and you will be able to see. I have made this slides very simple and basic. So KMC is also as simple as that. Just that you have to have that confidence to handle a 1 kg. So you know what is a, I think all of you go to gym. So 1 kg is going to be this much. So 1.5 kgs is going to be a little more than that. So 1.5 kg child on you, you're always scared where the child will fall, what will happen to the child. Child just came out of ventilator or a CPAP. So is it okay? So there will be a lot of problems happening and things running around. So once you start doing it, you will feel that okay, the child is better. And initial sessions, what I always say is the first day when we are putting the child to chest, one doctor or a senior staff is standing to monitor the vitals. So we keep the probe connected to the child so that there is no desaturation, there is no imbalance in the heart rate happening. So I think all these things you will learn if you're in an ICU or if you ever go there. And if any of you come to Chennai, you can visit and we can show you directly what is happening in an ICUs. Okay, anything else? Arushi, you have any other doubts? You have any other questions for them?
Uh, no, I don't. Questions are there. Why is exclusive breastfeeding important in KMC?
Okay, so exclusive breastfeeding, see, the thing is, we cannot always get into direct breastfeeding in a very small children. Like if it's a 28, 30 weeker, we first start with tube feeds and then go on to palatal feeds. So why breastfeeding is again important is breast milk has the maximum nutrients, and we call there is something called as a preterm breast milk and a term breast milk. So if the child is born preterm, the mother's body produces milk with a different composition with higher protein to cater the baby's needs. And also there are a lot of immunoglobulins, there are a lot of protected antibodies, IgA, IgM, which help in recovery of the child. So that is why I would say you can buy gold, you can buy platinum, you can buy anything in the world you want, but nothing replaces breast milk. So even if you give millions of dollars, that value what that breast milk has, nothing in the world has. That's what I can say as a pediatrician. I've been in this field for more than 10 years, worked in multiple places. So even today, I tell every mother, if you can do one thing to your child for a good health, please breastfeed. Don't go into formula or bottle. I know there are multiple challenges in breastfeeding, but I would say it is liquid gold. That's all. Okay, so I have a doubt. So mother has fever or any active infection, is kangaroo mother care still recommended or should it be temporarily withheld? Yes, it has to be temporarily withheld because we don't know what the mother is having. So that's why I said no, kangaroo mother care need not be the mother all the time. So at that point, we can have the family members like a father or a grandmother or a grandfather to step in and do this job. So we don't have to withhold the kangaroo care. So we can do it with the other members because child, again, preterm child are prone for infections. So when the mother is on fever or any active infection, we don't risk the exposure, but we will still continue, ask the mother to give some expressed milk and give it to the child via tube or palade so that the child continues to get the infection. Right, very nice question. In very preterm babies, beneficial. Okay, so oral feeds, I think very preterm, we see enteral nutrition again, we always enhance on enteral nutrition. So as early as if the child is hemodynamically stable, even 1 ml of feed we start giving. So kangaroo mother care gets beneficial to initiate feeding also, because as I said, the oxytocin is starting to release. So the mother will start getting good milk output also. And again, the baby's thermoregulation is starting to stabilize. Again, so if with the good bacteria in the stomach, So the bond will again help in recovery. So it's just a vicious circle. So I cannot say that not tolerating. See, kangaroo mother care per se is beneficial as a whole. So if the baby is tolerating feed or not, it's secondary. So we continue the skin to skin contact. Okay, so any other questions?
Ma'am, you said that not only the mother, but anyone from the family can actually do it. But isn't doing it with the mother more physiologically better because the baby already has connections with the mother, the heart rate, and all of that?
Yes, I agree. I think you have a very valid point. Yes, physiologically it's right, but we say tell the kangaroo care session. So 45-minute session minimum, 8 hours a day. So you think a mother who's just recovering can sit for 8 hours? So we have to give her some rest also, right? So physiologically we say as much as possible the mother to do, but at one point I am a mother too. I'm a doctor too. I know the child is important, the mother is equally important. So I say, why can't the mother take 1 hour or 2 hours sleep and the father can do the KMC instead of the mother? See, the thing is, the baby's cycle is not same. So you don't know when the child sleeps, when the child takes the feed. So we give 2 hourly feeds in an ICU or a 3 hourly feed. So the child is sleeping, awake. We don't know that cycle. So we can't keep calling the mother every time, right? So we need to give her some time to recover. So that is when we say we can have an alternative father. See, these days, fathers are helping us as much as mothers, right? So I'm able to give you a webinar at 8 o'clock when I have a toddler at home. So you think it's possible without a father? So things have changed, right? So we are evolving. So my son's grandfather is here to help me so that I'm able to teach you all. Okay, so it's all a combined effort. So we are growing with generations. So we are all evolving. KMC still remains important. So we also need the support from the family, right? Good.
Yes, ma'am. Thank you.
Yes.
Thank you, ma'am. On behalf of the organizing team, I extend our sincere gratitude to Dr. Apeksha Anand, ma'am, for delivering such an insightful and enriching session on KMC. Your valuable knowledge, practical insights, and dedication towards neonatal and pediatric healthcare have truly inspired all of us today. We are grateful for the time and effort you have taken to share your expertise with us. I am sure this session has enhanced our understanding of the importance of kangaroo mother care in improving newborn survival and well being.
Thank you so much for the opportunity. So I will drop in my email ID, and also any queries, you can anytime text me on Instagram or Facebook. Yes, I am this generation doctor, so I can help you out. So at any point, if each one of you help and motivate one mother, so we have 138 people in this audience. I think we can save those 138 babies and then many more. And you can again educate more people, right? Thank you so much and have a good day. I'm here.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
It is my honor and privilege to introduce our distinguished speaker, Dr. Elizabeth K. Ma'am. Dr. Elizabeth K. Ma'am is an eminent professor of pediatrics at Anantapuri Hospital and Research Institute, Thiruvananthapuram, Kerala. She holds remarkable academic credentials including PhD, MD, and DCH, and is also a fellow of the IAP as well as Royal College of Pediatrics and Child Health, UK. She has made significant contributions in the field of neonatal and pediatric care, especially in promoting newborn survival and kangaroo mother care practices. Her dedication, academic excellence, and commitment towards child health continue to inspire healthcare professionals and medical students alike. We are truly privileged and deeply honored to have you with us today, ma'am. I'm certain that today's session will be highly enlightening and insightful under your guidance.
Thank you, Arushi, for that nice words. So I am very thankful to the previous speaker, Dr. Apeksha, for setting the background. She has very nicely, simply explained to you all this. So I have a nutrition and child development book. So the chapter 1 is on breastfeeding, and there is a caption. The first page. I'm audible, I believe. Am I audible? Am I audible?
Yes, ma'am, you're perfectly audible.
So,
Yes, ma'am.
So the first quote I have given is, if ever I get a chance, I should love to be reborn, just to have the ecstasy of being refed by the kindly mother. And we say that breast milk is a lifesaver to millions of children across the globe. I understood this when I saw babies whose breastfeeding was abruptly stopped, and they came with severe acute malnutrition, even kwashiorkor. And you know what is the first syllable that a baby utters? I want you to put it in the chat box, and Arushi can track that and tell me later. So actually, it is ma. Ma means Amma, no? Amma, mother, mom. So that is unsaid love and unsung nurturing care. And what is this? The government program? There is a government program called Ma. That is mother's absolute affection. A mother who is giving her absolute affections can say that I am the best Ma in the world. That is, what is the absolute affection? That is breast milk and skin to skin contact. And another term which has come up is mom. We would love to say MOM, mother's own milk. And whoever is giving mother's own milk can put a post that I am the best mom because I am giving mother's own milk. And that is it. Because, you know, when we talk about breastfeeding to kids and younger children, they will think that breast milk is coming, every mammal is giving milk from the breast only, no? So, but then what is so special about this? So we say MOM, mother's own milk. Okay, the warm chain revolution it's a touch that really transforms. And I congratulate the Tamil Nadu Medical Students Network for this great initiative. And the attendance is so nice. 138 people joining is amazing. So you can take a pen and paper or somewhere you can write these answers. I'm giving you like all my classes start with a pre-test. Usually there will be more number of questions. Here I have put a few questions. Severe hypothermia in a newborn is defined as core temperature less than 35. Is it true or false? Brown adipose tissue is a primary organ for non-shivering thermogenesis. The delivery room temperature should be maintained at dash. And two multiple choice, because you love multiple choice, I know. Clinical features of hypothermia include all except tachycardia, tachypnea, hypoglycemia. There is an error. It is so 2 times hypoglycemia has come, and metabolic acidosis. Okay. So which is not seen in hypothermia. And regarding management of hypothermia, choose the incorrect action. Rooming in with the mother, maintain warm chain, initiate KMC for selected low birth weight babies, provide additional clothing, and promote breastfeeding. So this is just for your thought. We will be answering this later. Okay. And the history of KMC was said. So when incubators were short, there was shortage. Somebody thought of this, and we have acknowledged all of them, Ray, Martinez, all of them. But see, it was started copying a wet nurse. You know what is wet nursing? Wet nursing is when a mother goes and directly breastfeeds somebody else's baby. Nowadays, it is not considered very safe because of HIV infection, or they may be harboring some infections. We collect the breast milk into a breast milk bank and then pasteurize it, test microbiologically, and then dispense it. So that is breast milk banking. Otherwise, that is called CLMCs, that is comprehensive lactation management centers. So we don't know, the vet nurse name is not there. So I just wanted to acknowledge that vet nurse also. So it was copied, and so Ray and Martinez copied it, then WHO copied it. Now we are copying it. Okay. So it is a biological imperative from an innovation. And you know, mother's body is a habitat for the baby. Physiological regulation, behavioral activation, everything is happening when there is zero separation. So I want you to remember these words. That is Ma, mother's absolute affection, MOM, mother's own milk, then zero separation. Usually, mother and baby is getting separated in many hospitals, especially because it is preterm, because it is cesarean section. So many reasons are there to separate the mother and the baby. And when a mother and baby are separated, there is thermoregulatory collapse, there is respiratory distress, there is developmental stalling, metabolic stress, systemic threats, psychological discontinuance, mortality, poor weight gain, decreased bonding, apnea, infection, etc., etc. And maybe you remember your physics, that is hypothermia of physics is 4 mechanisms are there for heat loss: conduction, convection, radiation, evaporation. So I'm not going into all these basics. So when a baby, for example, usually cesarean babies are, when they are delivered, the mother is, the whole team is busy with the mother, and the baby will be brought out for the pediatrician to see, to a table. And the baby will be unattended usually. It will not be dried or no clothing. The baby will be lying like this. So what is the warm chain for a newborn baby? Maintaining normothermia. Maintain a warm delivery room. The temperature in the delivery room should be more than 25 degrees Celsius. If it is for the comfort of the doctor or the staff, we will put it at 22, 20, etc. So even if an AC is working, it should be above 25 degrees Celsius. This we call as thermoneutral environment for the baby. Then immediate drying. The baby should be with a wet cloth. The baby is lying. So baby should be dried, and baby should be immediately made warm. And that is, put the baby on the mother's bare chest. That is called immediate KMC. Now we are coming out with a new term. Every baby's right, it is every baby's right to get immediate skin-to-skin contact or immediate KMC. We are speaking about KMC for low birth weight, preterm babies. But first hour, it is the right of the baby to be with the mother. First hour, no separation. The mother and baby should be together, and the baby should be on the mother's chest. That is called IKMC or immediate KMC. This is slightly different from the other KMC, but this is the first step. Then we have to have clinical adjustments. We should not give bath to the baby immediately. We should not wipe off all the vernix caseosa on the baby, etc. And we have to ensure adequate clothing also. See, this is from an old module of WHO. When we were students, we got this: drying the baby, then keeping the baby on mother's chest, that is bedding in with the mother, etc. we used to say. And this mother, you see the first mother on the left, she delivered twin babies in a remote hospital, and the first twin died. And when we went as a unit of consultant, we went there to see this place, and I saw this mother struggling to give a KMC for her baby. So what I asked them to get a 32-inch banian with a sleeve. This was easily available in all the textile shops. So even if nothing is there, see how we managed. So the baby is put on the bare chest, but if it is a real preterm baby, there should be cap, socks, all these things should be there. And we usually give them a napkin also. And then put the baby on the mother's chest. Okay. So coming back to KMC, usually some case records we write, baby was immediately put to breast. But I find that baby takes some time to take breast milk. The first hour, what is happening? 9 things are happening. So all these things we can see only if there is zero separation. Birth cry, relaxation, awakening, then activity, then rest, then they crawl, then they familiarize, then they suck, then they sleep. So it will not be a good idea to push the breast into the mother's, into the baby's mouth immediately. That is why WHO says within an hour, and that is called the golden hour. And the positioning, everything was beautifully explained. I think these pictures are also self-explanatory. And the 2 foundation pillars of KMC is skin-to-skin contact and exclusive breastfeeding. There are a lot of sensory inputs going from the baby to the suckling. Everything is going to the mother's hypothalamus pituitary axis. And oxytocin rich, happy, joyful place should be there. Some labor rooms are quite terrific. There is a lot of shouting. There is a lot of loneliness. It may be very cold because the AC is put on like that. So we have to be very careful that we provide a thermal environment for the mother and the baby. And it is not terrifying, telling you a joyful pregnancy and a respectful oxytocin-rich maternity. So we have to maintain the room temperature about 25 degrees. This all we said. Immediate care is drying the baby, then skin to skin contact. Allow the baby to settle down. It has to pass through several stages before it can suck and settle down. And you know that there is a physiological dip in the blood sugar. At which hour? Hour 2. After first hour to the second hour, there is always a physiological dip. And the physiological dip can be tolerated up to permissive hypoglycemia is 25 milligram. For me and you, it is 70 milligram is hypoglycemia. And for a SAM child, it is 54. That we know. So here it is up to 25 in a stable baby. But if they are symptomatic, as ma'am was telling, previous speaker was telling, only stable babies should be taken up for this. And then we give them, what do we give them? Colostrum. Colostrum is metabolic gold. What is the proof that it is gold? The black meconium changes to gold and yellow stool. So we always tell, see, gold and metabolic gold has gone in. That is why the stool has become yellow. And it is empty volume. It may be only 10 ml. It may be only 5 ml. It may be 2 ml sometimes, colostrum. 10 to 40 ml in 24 hours. But it is a high yield energy battery. So colostrum plus frequent feeding stabilizes the physiology of the baby as well as the glucose levels. So this is new information that we are sharing. And we know the benefits to the baby was already mentioned, but there is a benefit for the mother also. Physiological facilities, ideal, that is the mother, even exclusive breastfeeding, bonding is coming. If the baby is far away, when visitors are around, the mother cannot feed also. And nowadays, photo shoot is also happening. Lot of cameras are facing on the newborn baby. These are all not good practices. Mother and baby should be together. They should be respected. And there is, so Mother's benefit is again physiological and psychological benefit for them. Okay. And are there any evidences? We always ask, no, is it evidence-based? Okay. 30 to 40% reduction in mortality, 72% reduction in hypothermia, 88% reduction in hypoglycemia, 65% reduction in nosocomial infection, 50% reduction in severe infection, 58% reduction in hospital readmission. It improves weight, length, head circumference, increased rate of exclusive breastfeeding beyond the newborn period. What else we want? See from Cochrane review. So there was a question, who all are eligible? So if stable, any baby more than 1.8 kg, 1.2 to 1.8 kg. So baby should be transferred for special care, maintaining KMC with the mother. But it may, sometimes they may need equipments also. Less than 1.2 kg, actually they have to be, their cardiorespiratory status has to be stabilized first, and then only we can give. Okay, so more than 1.8 kg, 34 weeker babies are usually more than 1.8. Initiate soon after birth. Others, we may have to stabilize them and then give. That is the thing I want to tell you. And what is the feeding policy? Tier 1 is direct breastfeeding whenever possible. A 34 weeker, that is late preterm, who is 1.8 kg usually, can have direct breastfeeding. And in tier 2, it is express breast milk. That is Pallada feeding, which madam was telling. And tier 3 is those babies less than 32 weekers and all, they may need 2 feeds. And see, is cesarean section a hindrance for IKMC? Can you see that inside the theater, the baby is put on the mother's chest? So even in cesarean babies, we are now practicing IKMC. So IKMC should be followed by KMC in those who are eligible for it. Other babies, bedding in with the mother. And so least maturity babies, they may need gavach feeding. Others can go for express breast milking, and more than 34 weekers can go for direct breastfeeding. When should we discontinue? And ma'am was telling you can give it for minimum 8 hours and maximum 24 hours. Up to 24 hours a day we can be given. So baby reaches 2.5 kg. Baby is actively wriggling out. Baby is not staying there. The baby is now active and is pulling limbs out of the binder, and excessive fuzzing is happening. So, and these babies can be discharged early, those who get KMC, because they will have weight gain, 20 gram per kg per day for 3 consecutive days. And mother is now confident to handle the baby and give feed to the baby. So discontinuing is 2 kg also. If the baby wriggles out, we may discontinue. Otherwise, if the baby is okay, we go for 2.5 kg. And mothers can still optionally use KMC post-bath. See, for example, it is raining outside and the baby had a bath and the baby is shivering thermogenesis. When they shiver, they produce heat. And the adipose tissue, which is brown adipose tissue, which is there in the axilla and groin. And that is all essential fat. That is why it is lipolyzed first in some cases also. That is in malnutrition, we say loose skin folds in the axilla and groin first. So during particularly cold nights, etc., she can do that. So antenatal sensitization is very, very important. We should give a counseling. We should show them how it is done. And when we have the antenatal classes, usually the mother and a helper or a friend will come. But we should have the whole family. The decision makers are the father, maybe the mother-in-law. There are other decision makers in the family. Everybody should see. And we can say that even if you have a preterm baby, we will okay. So this is it. So antenatal sensitization is very important. It is said that most mothers make the decision what they are going to feed in the antenatal period itself. Are they going to give formula? Are they going to breastfeed, etc.? See, this is something wonderful. We have a new concept called MNCUs, Mother Neonate Care Units. Mother and baby are in the same unit. Usually we have mother's ICU separate, baby's ICU separate. So we can have, and this was a hit photograph, viral. What is it showing? A young boy has been praised online because he is giving KMC along with the father. The mother got very sick and she had respiratory distress and was transferred. And so this happened. And this is called Embrace. This was innovated by few engineers and made it a startup. This has a grain that is a heatable pellets in it. So that can be heated to the optimum temperature and the baby can be wrapped in it. So if the mother is away or father is not there, anybody else is not there, this can be done. This is good for, this Embrace is good for transporting a baby. Maybe we want to transport the baby to the cardiology unit for echo or radiology unit for a ultrasound, etc. So now I have a case scenario for you. Rina, 27-year-old mother, delivered a baby girl, 34-weeker. I said 34-weeker is usually 1.8 kg. So this is 1.6. So what is your inference? It is again a SGA baby, a preterm SGA. She complains her baby feels cold and is it? Okay. Can I continue? And isn't gaining weight. She is highly anxious and lacks confidence and fears she isn't producing enough milk. And the physician advises KMC. How is it going to help? So what is the baby's core problem? Weight gain. And mother's core problems are anxiety, lack of competence or confidence, apprehension about lactating. So what exactly constitutes skin to skin? The first component of KMC where the baby is kept in the mother's chest. So KMC is going to help both all these problems, prematurity, weight gain, hypothermia, etc. So we have to champion the biological imperative. Let us all become champions for warm chain for a baby. So now again the question is coming. So severe hypothermia in a newborn is less than 35. Or brown adipose tissue is the primary organ for thermogenesis. Delivery room temperature should be maintained at what temperature? And which of these four is not there in hypothermia? And regarding management, which is incorrect? I hope all of you have the answers with you. So I'll give the answers. Severe hypothermia is less than 35 is not correct because severe is 32. Moderate is 32 to 35.9. And 36 to 36.4 is cold stress. Brown adipose tissue, that is true. And delivery room temperature should be more than 25 degrees Celsius. And the incorrect one is initiate KMC for selected low birth weight babies. It is not for selected. It is for everybody. And IKMC is for even term normal babies. So that is the answer. Now, because you are all so much enthusiastic about breastfeeding and all, I am going to show you a video. See this video. This is, what is this called? Can you type what do you see? This is a term stable baby. That is why the baby is not clothed. See what the baby is doing. See, 95% confidence in the mother and 5% skill in the mother. But the 95% skill in the baby. See how the baby is going and attaching to the breast. So baby will take little time. I hope this is called, anybody answered? This is called breast crawl. So KMC and breast crawl. And what is this? This is swaddling a baby. How many of you know how to swaddle a baby? As a boy or a girl, you should know it. As a father or a mother, you should know it. As a doctor or a nurse, you should know it. So this is it. And I stop here. Now, okay. So I'm happy that all 145 people are still there. Arushi, Akash, thank you very much for this excellent opportunity. I hope you could, with both the lectures, you could understand better.
Yes.
Yeah, you can. You can.
Yeah, Akash.
What are the 3 core pillars of the KMC clinical model? We have a lot of answers. The correct answer is B. According to the WHO, when should the KMC be initiated for stable infants weighing less than 2000 grams? Correct answer is B. What does the term continuous KMC specifically refer to? C. What is the mandatory criterion for the kangaroo discharge of a preterm infant from the hospital? B. Which neurohormone increases in mothers during KMC, aiding in bonding and milk letdown? C. How does KMC affect breastfeeding outcomes? C. What is the primary sign that a baby is successfully thermoregulating during KMC? B. Which of the following defines the kangaroo position? B. What is the ideal duration for a single session of KMC? A. What should the baby wear during KMC? B. Respected dignitaries, speakers, seniors, and dear participants, as we come to the end of today's webinar, it is my pleasure to deliver the vote of thanks. Yeah, okay. If anyone has doubts, guys, please do ask either in chat box or you can ask directly also.
Okay, so I would like to add one point. So we have all read ma'am's books. So since residency, I think I am very junior to ma'am, and literally from first to last page, that book would used to be with us in all OPD, and I'm so grateful that today I'm able to give a talk with her. Ma'am, you have been inspiring a lot of youngsters like me today. And I have exclusively breastfed my child and still feeding it 1.5 years. So I think people like ma'am are like great to be around and great pediatricians for young generation like us. I think all of you are very lucky that she spent her very precious half an hour with us today and gave us so many new things and all the recent advances. Thank you so much, ma'am. Your book is still on my OPD every day.
So I'm very happy and thankful to you. I'm very happy that uh, you gave the insightful talk from your heart, and you are the best mom. You can claim that. Thank you very much. So we all are going to become champions of warm chain, including KMC. I think you should make a pledge that I will be a champion for the warm chain.
Ma'am, we have a doubt in the chat box. Preterm babies have immature sucking reflex and poor coordination of sucking, swallowing, and breathing. In such babies, how does KMC help in the development of feeding skills and neurodevelopment?
Actually, I said that 34 weeker babies can coordinate sucking, swallowing, and breathing. But a baby who is born 28 weeker need not wait to become 34 weeker to get this maturity. This matures fast. For example, 28-weeker may develop this skill earlier than the other baby. And in promoting that, this bonding with the mother and the humoro, immuno, metabolic, all the effects from the mother is going to help. And faster weight gain, faster thermoregulation, no hypoglycemia, no infection, that is going to help them. For example, a 28-weeker need not wait 6 weeks to get this qualities developed. If KMC is given, they develop it faster. But if they have infection, cold stress, everything, this process also will get delayed. I think this is a great model from Tamil Nadu that can be replicated in other states also. Actually, 1 week ago, I was sharing case presentation from Andhra Pradesh. 3 of them presented cases, and we gave the positive points, negative points, and then one person was awarded who is the best and all. Some very seniors also have joined.
Yes,
One
we
of
have a
teacher of
Srinivas
teachers,
sir. Yeah, we
Srinivas
have
himself.
sir. So nice
Yeah,
to see you, sir.
sir, please tell few words of blessing to this and very enterprising undergraduates who have done this. Sir, maybe he's in US, I think, odd time. So maybe. Okay, I think we can conclude. Sir is here. Sir. Okay.
Ma'am, can we conclude?
Yeah, we can.
Respected dignitaries, speakers, seniors, and dear participants, as we come to the end of today's webinar, it is my privilege to deliver the vote of thanks. First and foremost, I extend our heartfelt gratitude to Dr. Apeksha Anand ma'am and Dr. Elizabeth K. ma'am for sharing your valuable time, knowledge, and experiences with us. Your insightful sessions on kangaroo mother care have truly enlightened and inspired all of us, and we are deeply honored by your presence today. I would also like to express a sincere thanks to our respected state leaders and seniors for their continuous support, encouragement, and guidance throughout the planning and execution of this webinar. A special note of gratitude to Dr. Arunagiri sir, Dr. Ajay Karthik sir, Dr. Bala Hariharan sir, and Dr. Hariram sir for your constant motivation and leadership. My heartfelt appreciation also goes to the entire state team for their coordination and support in making this event successful. Finally, a big thank you to our organizing team, Akash, Grace, Sam, Kirtana, Pavi, Fayaz, Hariharan, and myself for the teamwork, dedication, and hard work behind the scenes. And of course, thank you to all the participants for joining us and making today's session interactive and meaningful. With the gratitude, we conclude today's webinar. Thank you, everyone. Thank you so much, ma'am, for taking out your valuable time and being with us here today. It was truly enlightening, ma'am. Thank you so much.
We're gonna say hi, bye from my son. Bye. Bye.
Please make sure to fill the form or else you will not receive your certificate.